Welcome to Med Studious. This lecture covers one of the most clinically demanding and ethically significant areas in all of forensic medicine, the forensic evaluation of sexual offenses. When a survivor of sexual violence presents to a medical facility, the physician's role is dual and non-negotiable: to provide compassionate, trauma-informed clinical care and simultaneously to collect, document, and preserve evidence that may determine the outcome of a criminal prosecution. Every step of this process, from requisition to report, is governed by standardized protocols, and any deviation can compromise both the patient's treatment and the integrity of the legal case. The tools you will encounter throughout this examination include sterile swab tubes for biological specimen collection, sealed evidence envelopes maintained under strict chain of custody, fine medical scissors for trace evidence and matted hair collection, and glass slides for microscopic analysis of cellular and seminal material. The concept of chain of custody is not bureaucratic formality. It is the legal spine of the forensic case. Any break in the chain, an unlabeled sample, an unsealed envelope, an undocumented transfer, can render critical biological evidence inadmissible in court. This dossier approach to the forensic sexual offense examination transforms a deeply sensitive clinical encounter into a legally defensible, scientifically rigorous process. Let us begin with the classification of offenses.
Before performing any forensic examination, the clinician must correctly classify the reported offense, because the category of offense directly determines the examination protocol, the specific samples collected, and the anatomical regions assessed. Sexual offenses are divided into four major forensic categories. The first is the natural sexual offense, legally defined as rape, characterized by penile-vaginal intercourse performed against the will or without the consent of the victim. This is the most commonly reported category and involves specific genital examination protocols. The second is the unnatural sexual offense, defined as penetration contrary to the order of nature, encompassing oral and anal intercourse. A critical legal development. Following the Supreme Court's reading down of Section 377 of the IPC in the Navtesh Singh Johar judgment of 2018, unnatural sexual acts performed between consenting adults are no longer criminalized in India. However, they remain criminal offenses when performed without consent. The third category is sexual harassment and indecent assault, non-penetrative offenses involving unwanted physical contact, gestures, voyeurism, disrobing, and threats designed to outrage modesty. These are covered under BNS sections 74 through 77. The fourth category is paraphilias, sexual gratification achieved through atypical objects, behaviors, or targets rather than standard intercourse. Forensic recognition of paraphilic patterns is essential because they frequently coexist with other sexual offenses and require specialized psychological and forensic assessment.
Two of the most commonly conflated categories in forensic practice, sexual harassment and indecent assault, have distinct legal definitions, distinct mechanisms, and distinct institutional handling protocols. Mastering this distinction is essential for both examinations and clinical documentation. Sexual harassment, governed by BNS Section 75, operates through intimidation, verbal threats, and the coercive demand for sexual favors in exchange for rewards, a pattern commonly described as quid pro quo harassment. The defining forensic characteristic of sexual harassment is that it does not require physical contact and does not require any act to be completed. The threat or demand itself constitutes the offense. Institutionally, sexual harassment in the workplace must be handled by the Mandatory Internal Complaints Committee, formerly called the Vishaka Committee, established under the Sexual Harassment of Women at Workplace Act of 2013. Any workplace with more than 10 employees is legally obligated to maintain this committee. Indecent assault, governed by BNS Section 74 through 77, involves criminal force applied specifically to outrage modesty. This category covers physical assault under Section 74, criminal disrobing under Section 76, and voyeurism, commonly called the peeping Tom offense, under Section 77. The key clinical distinction: indecent assault always involves physical action, forced touching, or the deliberate violation of physical privacy boundaries without consent. In forensic terms, indecent assault may leave physical evidence, bruising, tissue trauma, DNA transfer, while sexual harassment typically does not.
The legal definition of rape in India was fundamentally transformed following the Justice Verma Committee recommendations in the wake of the December 2012 Delhi gang rape case. The reforms, now codified in BNS Section 63, significantly expanded the definition of rape beyond the narrow historical framing of penovaginal penetration. 3 expanded physical parameters now define what constitutes penetration for the purposes of rape law. First, penetration to any extent. The law requires only the slightest degree of penetration. Complete penetration is not required. Second, utilizing any object or body part. The offense is not limited to penile penetration. Any body part or object used to penetrate constitutes rape under this definition. Third, penetration into any opening of the body, the vagina, mouth, urethra, or anus, or the act of forcing the victim to penetrate another person. 7 circumstantial triggers exist, any one of which constitutes an offense. These are acting against the victim's will, acting without her consent, obtaining consent under fear of death or serious hurt, obtaining consent through deceit, intoxication, or misidentification of the accused, the victim being under 18 years of age, and the victim being unconscious or otherwise unable to communicate. A critical legal note: under this specific statute, only a man can be accused of committing rape. This gender-specific legal actor provision has been debated, but remains the statutory position under BNS Section 63.
Consent is the single most contested element in rape prosecutions, and forensic medicine practitioners must understand its legal architecture precisely, because their clinical documentation of consent-related findings can determine a case's outcome in court. The law draws a critical distinction between 2 concepts that the layperson might conflate: will and consent. Will refers to wholehearted, autonomous, voluntary participation, the genuine desire to engage. Consent, in a legal sense, refers to a verbal or expressed agreement, which may or may not reflect genuine will. The Mathura case of 1979, one of the most consequential and controversial judgments in Indian legal history, initially established a precedent that verbal consent, even if given under implied coercion, was sufficient. This judgment catalyzed massive public outcry and directly led to the 1983 amendments to the Evidence Act. Under modern law, Equation 1 establishes that if consent is compelled by fear or harm or threat, even if verbally expressed, the will is absent, rendering the consent legally void. The act constitutes rape. Equation 2 establishes the doctrine of statutory rape. A minor may participate with apparent willingness, but lacks the legal capacity to provide valid consent, regardless of their expressed agreement. The age threshold is 18 years. A profoundly important evidentiary rule governs this domain. The burden of proving that valid consent existed lies entirely with the accused. The female victim is not required to prove she withheld consent. This reversal of the standard evidentiary burden is a cornerstone of modern rape law in India.
Beyond the baseline definition of rape under Section 63, the BNS recognizes a spectrum of aggravated and circumstantially elevated scenarios, each carrying enhanced punishments reflecting the heightened violation of trust, power asymmetry, or physical severity involved. BNS Section 66 represents the apex of physical harm, rape causing the victim's death or resulting in a persistent vegetative state. The punishment is either death or rigorous imprisonment for the remainder of the offender's natural life. This section reflects the legislature's recognition that sexual violence can be lethal. BNS Section 67 addresses marital rape during legal separation, a husband having non-consensual intercourse with his wife while a formal judicial separation order is in effect. This is a legally recognized and punishable offense. BNS Section 68 governs custodial rape, perpetrated by individuals in positions of authority or custody over the victim, including police officers, prison wardens, hospital management personnel, armed forces members, and public servants. The trust relationship that defines custody fundamentally elevates culpability. BNS Section 69 covers rape by deceitful means, consent obtained through false promises of marriage, impersonation of another person, or deliberate misrepresentation of identity. BNS Section 70 and 71 address gang rape and repeat offenders respectively, both attracting mandatory minimum 20-year sentences extending to life imprisonment. Finally, BNS Section 72, often overlooked but critically important, strictly penalizes the public disclosure of a rape victim's identity through any medium, including print, digital, or broadcast media.
The forensic examination of a sexual offense survivor is among the most procedurally regulated clinical encounters in medicine, and for good reason. Every step of the pre-examination protocol has legal consequences. There are 5 mandatory requisites that must be satisfied before the examination begins. Step 1 is the requisition. The examination can be requested by any police officer, regardless of rank. There is no minimum rank requirement for victim requisition. This is an important distinction from the examination of the accused. Step 2 is personnel. The examining physician must preferably be a nearby female doctor. While a male doctor may examine in the absence of a female physician, this must be documented, and every effort to secure a female examiner must be demonstrably made. Step 3 is the chaperone. A female chaperone is legally mandatory throughout the entire examination. Preferably, this is a female relative of the victim. Alternatively, a trained female nurse fulfills this requirement. No examination may proceed without a chaperone present. Step 4 is the strict tripartite consent, an absolute legal requirement. 3 separate and explicit consents must be obtained and documented. Consent for medical treatment, consent for the medical legal examination itself, and consent for biological sample collection. If the victim refuses any component, that component cannot proceed without a direct court order. No exceptions. Step 5 is the targeted history. The examination must be strictly guided by the victim's reported account. If the reported offense was exclusively oral, vaginal swabs are not collected. The history determines the protocol.
The Sexual Assault Forensic Evidence Kit, commonly known as the S.A.F.E kit, is the standardized tool for systematic biological evidence collection in sexual offense cases. Every component of the kit serves a specific forensic purpose, and the collection sequence is designed to maximize evidence recovery while maintaining chain of custody integrity. The examination begins with the undressing protocol. The victim is instructed to undress while standing or sitting over a large, clean white paper sheet spread on the floor. This is not merely procedural, it is forensically critical. As clothing is removed, trace evidence that has adhered to fabric, the attacker's hair, skin cells, textile fibers, falls onto the paper and is collected as the sheet is carefully folded inward and sealed. Each clothing item is packaged separately in a paper bag, never plastic, to prevent biological degradation from moisture. The matted hair protocol involves the careful use of scissors to cut and collect matted pubic hair. Matted pubic hair strongly indicates the presence of dried seminal fluid, which acts as a biological adhesive. This specimen is a high-value forensic sample. Nail clippings are collected from both hands and preserved separately in labeled envelopes. During struggle, the victim may scratch the attacker, trapping their skin cells, rich in DNA, under the fingernails. External injury scanning involves systematic assessment for love bites, technically petechial bruising caused by negative pressure rupturing subdermal venules, typically found on the face, neck, and breast areas, and struggle marks, such as grip bruises and fingernail scratches, on the limbs, back, and thighs.
The genital examination of a sexual offense survivor requires both a systematic anatomical approach and familiarity with the specific injury patterns associated with non-consensual penetration. 4 anatomical zones demand particularly forensic attention. The clitoris and labia are examined for edema, erythema, and lacerations. These injuries are particularly prevalent and severe when there is significant physical size disparity between the victim and the perpetrator, most critically in pediatric cases, where the anatomical dimensions of the child's genitalia are dramatically mismatched with an adult perpetrator. The fossa navicularis and posterior fourchette, the shallow depression immediately anterior to the hymen and the junction of the labia minora at the posterior commissure, are the most common sites of genital injury in adult rape cases. Their vulnerability arises from the absence of underlying tissue cushioning, making them susceptible to shear and compressive forces during forced penetration. The hymen is carefully examined, with tears and defloration most characteristically occurring at the 5 o'clock to 8 o'clock positions of the clock face reference system, corresponding to the posterior half of the hymeneal ring where tissue is thinnest. Toluidine blue dye application, combined with colposcopic magnification, is the gold standard technique for revealing microlacerations that are invisible to the naked eye. The dye is absorbed by denuded epithelial cells at laceration sites and appears as a deep blue stain. Finally, all genital findings are documented using the TEARS diagnostic framework: tears, ecchymosis, abrasions, ruptures, and superficial lacerations.
Biological specimen collection in the forensic sexual offense examination follows a 4-swab intelligence protocol designed to extract maximum forensic information from vaginal samples, including those from cases where the perpetrator is azoospermic or vasectomized. 4 anatomical sites yield swabs: the inner thigh, the low vaginal wall, the high vaginal wall, and the posterior fornix, the deepest recess of the vaginal vault, where seminal fluid pools by gravity and is preserved longest. From these sites, 4 distinct analytical pathways are pursued simultaneously. Swab 1 is prepared for microscopy, fixed immediately on a dry glass slide to preserve cellular morphology for direct microscopic visualization of spermatozoa, their presence, count, motility status, and structural integrity. Swab 2 undergoes seminal fluid chemical analysis. This swab tests for the biochemical constituents of seminal plasma, most importantly, acid phosphatase, choline, and prostate-specific antigen. This analysis confirms the presence of seminal fluid even in cases where no spermatozoa are visible, critical when the attacker has undergone vasectomy or has primary azoospermia. Swab 3 is dedicated to DNA analysis, extracting the genetic fingerprint of any biological material present for definitive perpetrator identification through STR profiling. Swab 4 undergoes species-specific chemical analysis, determining whether the biological material recovered is of human or animal origin. This is a forensically necessary step, particularly in cases involving multiple biological deposits or environmental contamination.
One of the most consequential skills in forensic sexual medicine is the accurate microscopic interpretation of spermatozoa, because the conclusions drawn directly determine whether a survivor's account is corroborated as recent, remote, or inconclusive. The interpretation follows a standardized decision algorithm. The first question: is at least one morphologically complete spermatozoan present, meaning a sperm cell with both an intact head and tail? If the answer is no, and only broken or fragmented sperm heads are visible, or no sperm are detected at all, the finding is reported as inconclusive. This is a critical forensic rule. A finding of only broken sperm must never be reported as evidence of positive sexual activity. Broken sperm heads are frequently artifactual and have no reliable evidentiary value. If at least one complete spermatozoan is identified, the second question is the sperm motile? If yes, motile spermatozoa are present, the conclusion is recent sexual intercourse, typically within the preceding 6 hours, as spermatozoa maintain motility in the vaginal environment for approximately 3 to 6 hours post-ejaculation. If complete but non-motile spermatozoa are present, the conclusion is remote or non-immediate sexual intercourse. Intercourse occurred, but not in the recent hours. It is important to note that spermatozoa can survive in the vaginal vault for up to 5 days, in the cervical mucus for up to 7 days, and in the posterior fornix for up to 3 days. The forensic significance of these survival windows is that the absence of motility does not invalidate the finding of penetration.
The forensic examination for anal penetration, historically termed sodomy, and legally also known as buggery or Greek law, requires a distinctly different anatomical approach and a separate set of clinical findings. The examination is conducted with the patient in the knee-elbow position, with the lateral position used as an alternative for individuals who find the primary position uncomfortable or traumatic. The clinical findings are classified into two categories: habitual markers and non-habitual markers. Habitual markers are findings that indicate repeated or chronic anal penetration over time. These include a funnel-shaped anus, resulting from chronic smooth muscle relaxation and loss of the normal anal sphincter tone. There is often flattening of the anal folds, chronic anal fissures, linear tears in the anal mucosa, and alterations in the hair pattern surrounding the anus due to chronic skin changes. The lateral buttock traction test is a specific clinical maneuver. When the buttocks are gently spread, abnormal passive anal dilation of 20 to 50 millimeters is considered a positive indicator of habitual penetration. Non-habitual markers are findings consistent with recent forceful penetration without chronic history. These include deep lacerations, acute bruising and contusions, and excoriation of the perianal skin, all suggesting recent forceful assault with significant physical disparity between perpetrator and victim. The forensic lexicon for this area includes specific terminology. Pederasty refers to anal penetration of a child victim. Gerontophilia refers to an elderly victim, and catamite refers to the passive recipient of the act.
The forensic examination of the accused in a sexual offense case differs fundamentally from the examination of the victim in both legal authority and clinical focus, and these differences are frequently tested in examinations. The first key distinction is in requisition authority. For the victim examination, any police officer, regardless of rank, may submit the requisition. For the accused, the requisition requires a minimum rank of sub-inspector. This procedural asymmetry reflects the greater legal weight of commanding an examination of a suspect. The second key distinction is consent. For the victim, tripartite consent is absolutely mandatory, and the examination cannot proceed without it unless compelled by court order. For the accused, consent is not mandatory. The police hold the legal authority to compel the accused to submit to forensic examination, even if the accused explicitly refuses. This compulsion power exists because the examination of the accused is a state investigative function, not a therapeutic interaction. Two clinical markers are specifically sought on examination of the accused. Clinical marker 1 is smegma, the cheesy white secretion composed of desquamated epithelial cells and sebaceous material that accumulates under the prepuce. Smegma takes approximately 24 hours to accumulate following the last washing or sexual activity. Its presence strongly suggests that the accused has not bathed or engaged in sexual activity within the preceding 24 hours. Absence of smegma suggests recent washing or recent sexual activity. Clinical marker 2 is vaginal cell detection, using Papa-Nicolau staining on penile aspirate to identify female epithelial cells, and the Lugol's iodine test, in which iodine paper applied to the penis turns brown in the presence of vaginal glycogen, confirming recent sexual contact.
The Protection of Children from Sexual Offenses Act, universally known as POCSO, enacted in 2012 and strengthened by amendment in 2019, is India's most comprehensive legislative instrument for protecting children from sexual abuse. It operates as a gender-neutral shield resting on 4 foundational pillars. The first pillar is absolute gender neutrality. Unlike BNS Section 63 on rape, which specifies a male perpetrator, POCSO protects all individuals under 18 years of age, regardless of gender, and can hold both males and females equally accountable as perpetrators. This reflects the Act's recognition that child sexual abuse does not conform to a single gender pattern. The second pillar is mandatory legal reporting. Under POCSO, every person who has knowledge or reasonable suspicion that a child has been sexually abused bears a strict legal obligation to report this to the Special Juvenile Police Unit or local police. For physicians, this obligation is absolute and non-discretionary. Failing to report a suspected case of child sexual abuse is a punishable offense under the Act, making POCSO one of the few statutes that creates criminal liability for clinical inaction. The third pillar is the child-friendly mechanism. POCSO mandates that trials must be completed within 1 year of the offense, conducted through special juvenile police units, with investigation conducted at the child's home rather than at police stations, to minimize secondary trauma.
The fourth pillar is comprehensive scope. POCSO covers penetrative assault, non-penetrative assault, sexual harassment, child trafficking, child pornography, and aggravated offenses, including acts committed during natural calamities or by persons in positions of trust.
Paraphilias, defined as recurrent, intense sexual arousal to atypical objects, situations, or individuals, constitute a distinct forensic category because they frequently coexist with criminal sexual behavior and require specialized clinical recognition. The DSM-5 distinguishes between a paraphilia and a paraphilic disorder. The latter involves personal distress or harm to others. The forensic classification is organized by mechanism of gratification. Visual and auditory paraphilias include voyeurism, also called scoptophilia or the peeping Tom disorder, characterized by persistent arousal from observing unsuspecting individuals in private moments. Scatologia involves obtaining gratification through making obscene telephone calls to strangers. Exposure and touching paraphilias include exhibitionism, achieving gratification through exposing genitalia in public, behaviors commonly described as mooning or streaking. Frotteurism, also called touchism, involves obtaining gratification from rubbing against or touching non-consenting persons in public spaces, such as crowded transport. Pain and control paraphilias include sadism, deriving pleasure from inflicting physical or psychological pain, and masochism, clinically termed algolagnia, deriving pleasure from receiving pain. Fetish and bizarre paraphilias include transvestism, gratification from cross-dressing, and critically, amber sexual asphyxia, the highly dangerous practice of restricting cerebral blood flow through self-strangulation or partner restriction to intensify orgasm, which causes numerous accidental deaths annually. Necrophilia, sexual acts with deceased persons, is classified here. Finally, familial paraphilias, collectively termed incest, are defined by sexual relations between blood relatives, and subcategorized by the Electra complex for father-daughter relationships, the Oedipus complex for mother-son, and the Pharaoh complex for sibling relationships. Note that incest itself is not classified as a standalone criminal offense under standard Indian criminal law, though associated acts may attract other criminal provisions. If this video helped you master forensic medicine, please like, comment, share, and subscribe to Med Studious for more high-yield content.